Welcome to AHRQ's webinar on optimizing data visualization to improve care. Although a few people are still logging in, we're going to go ahead and get started on time. My name is Roland Gamache, and I will be moderating today's webinar. I currently serve as a staff fellow for the Division of Digital Healthcare Research, which is part of the Center for Evidence and Practice Improvement at AHRQ. The agenda for today's webinar is now displayed. Please note that we are recording this webinar, and that the recording and slides will be available on the AHRQ Digital Healthcare Research website in a few weeks. You'll be notified by email once it's available. We are pleased to have with us today an esteemed group of presenters. They include Dr. Richelle Koopman from the University of Missouri, Dr. Gabriela Schmajuk from the University of California, San Francisco, and Dr. Daniel Malone from the University of Utah. This webinar is accredited by Affinity CE. If you're interested in receiving continuing education credit for participating in this activity, information on how to claim that credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. For the purposes of accreditation, let me note that AHRQ, Ph.D. Solutions, and Affinity CE have no financial interest to disclose. Dr. Schmajuk, Koopman, and Malone have also no relevant financial interests to disclose. Also, please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the Q&A panel located at the right of the PowerPoint slides. Please note, please include the presenter's name or their presentation order number, first, second, third, with your question. As a reminder, participants are in listen-only mode, so to ask questions, you'll need to use the Q&A panel. This slide shows the learning objectives for today's webinar. By the end of this presentation, you should be able to describe the development and implementation of an application that displays real-time visualizations of pro data during clinical encounters for patients with rheumatoid arthritis. Describe creation and testing of intuitive health data visualization, and explain how the visualization tools lead to better inform patients and improve care decisions, and discuss the development and evaluation of a shared decision-making dashboard for presenting individualized risk of harm from drug-drug interactions. Now it's my pleasure to introduce our first presenter, Dr. Richelle Koopman. Dr. Koopman is the Jack M. and Wilfred S. Cowell Professor and Vice Chair for Research and Faculty Affairs for the Department of Family and Communication Medicine at the University of Missouri. She's a practicing family physician and co-author of the ebook-inspired EHRs, Designing for Clinicians. Dr. Koopman is committed to designing and testing data visualization and workflow that makes it easy for patients and physicians to make good decisions to improve health. And now I'd like to turn over control to Dr. Koopman.
Thanks. I'm going to talk with you all about some things that we did to look at blood pressure control among patients with hypertension. And having trouble advancing the slide. Okay, great. Okay, and the work was funded by AHRQ and our past project, but also going into our current coach project with David Dorr from Oregon. So you've already seen some of the learning objectives, but basically I want to talk with you all about how we thought about fusing good design and clinical and patient information needs to create something that would be useful for everyone in deciding about hypertension control, which is not a very good quality measure in most cases in the United States. It's a great quality measure, but it's not attained enough. So one of the big problems that we tackled right off was the problem of home blood pressure. And on the left, you can see this. This is for one of my patients. She takes her blood pressure 6 times a day, and brings me 3 of these sheets every 3 months. And that's a lot of data to think about. And really, it's beyond human capability to be able to do that. So I'm foreshadowing our solution of getting home blood pressure into clinical workflow. And I'll tell you about how we did that. There's a lot of people in our multidisciplinary team, but it's a big factor in how we did this. And I just want you to notice all the different disciplines in purple: family physician, quantitative psychologist, decision science, usability, patient engagement, social work, human factors engineering, computer science, informatics. It goes on. We really had a lot of different expertise and needed to learn to all talk to one another about these problems. But it really takes all these perspectives to get this right, I think. This is work from over 6 years, and there were a variety of methods. The first was a human-centered design, iterative 10 focus groups and key informant interviews with patients and physicians beginning back in April 2015. And so we would iterate between each focus group. Along with that, we wanted to assess the effect of the form of data visualization on patient risk perception. It's really important to know if we're actually influencing how people perceive control, because it's an important decision. And we did that with online experiments with a U.S. national sample, with 6 smaller experiments, and then a larger one at the bottom to look at health literacy, numeracy, and graph literacy, and see how that was affected by different presentations of the data, including our final design of smooth data. We also explored the use of fuzzy logic and linguistic summarization of data through engineering methods, and pairing blood pressure data visualization with a medication timeline using a usability task analysis. Finally, after the EHR implementation phased from 2018 to 2019, we did live recordings of 89 patient visits, including screen capture, with 15 physicians, and used conversation analysis to see how the data visualization affected the flow of the visit when compared to paper. So I'll be talking about things that those methods generated. So in designing this data visualization, our team had certain principles, and we started out with these principles, and I think it's really important to bound the work in this way. We set out to design for the primary care setting because 85% of hypertension care is provided in the primary care setting. And we wanted to design for shared decision-making. While it was primarily an EHR visualization, we wanted something that physicians and patients would be able to share. And so we needed to satisfy both of their information needs, comprehension, and workflow. We wanted intuitive design. We didn't want to have to educate people about how to use the tool, that it would just be so usable that people would just be able to understand how to use it. And really wanted to be cognizant of how the data visualization could affect decision-making and, in fact, test that. Here's an example of not designing for primary care. So this comes from an anesthesia operative setting. And in that discipline, it's very common to represent blood pressure as a caret and inverted caret, as you see at the bottom of the screen, and to include down here. And that is not the way that we are used to visualizing blood pressure data in primary care. And so it's important to design for how people expect to see things. And this is a big example of how you wouldn't do that. A few other things. We wanted to have systolic and diastolic data on the same graph as 2 line graphs, but on the same screen. We ended up using color to differentiate. And to satisfy the home information need of clinic and home data, we used different symbols on the same graph and eventually the same line. We included the raw numbers, and we stacked a graph with the medication timeline so that people could understand the effect of medications on blood pressure over time. We also included shaded goal ranges, and I'll show you that. customizable goal ranges. And we were alert to the patient burden of entry. And so automated data upload via Bluetooth is something that people still need to investigate. And importantly, we're going to talk a lot about understanding data variability relative to control and annotations. So, we began here at the beginning where we were trying to figure out how can we represent both clinic and home blood pressure. And in panels A and B are represented that you could toggle back and forth between them, where on the left, the clinic with blood pressure with the squares is represented in the more vivid line, and then becomes softer in panel B, where the home blood pressure takes prominence. Ultimately, we settled on panel C, that they're both on the same line, but different symbols, and the user doesn't have to toggle. We also decided that we were going to put the systolic and diastolic in the same graph space, which is the way that people are used to seeing this, and it condenses the information. And line graphs are continuous, despite we know that there's gaps in data between time points, and that the lines suggest a trend that may or may not be present. We gave equal weight intentionally to home blood pressure with clinic blood pressure. And we also experimented with open versus closed data points for home blood pressures, depending if the home blood pressure monitor had been validated when it was brought into the clinic, although that was not operationalized in the final design. For goal ranges, in the leftmost panel, there's no goal ranges. And you can see the effect of the successive layering on of indicators of goal. The lines in B help, but the shaded goal ranges in C are the most effective in aiding the viewer to be able to say, this is in or this is out of goal. We're capitalizing on the pre-attentive attribute of color and enclosure to simplify visual processing for the user. And so it's real easy to see in or out, and it's a snap-second decision using the fast parts of our brain. We initially didn't use color because we thought that people might want to print these graphs. So we designed in grayscale, but we abandoned that pretty quickly. We wanted to emphasize outliers because, of course, high blood pressure is a concern. And so we did experiment with color while we were still in grayscale to use an alarm color. And I can tell you that we were trying to increase emotional salience for the viewer, but both the physicians and the patients hated these. They felt that they were redundant with the goal ranges. And one of the patients said, it just doesn't seem to clarify anything. I can see that orange fill means out of range. I don't need the orange. And so we were giving two signals, the goal range and the outlier color, and the people just told us, you don't need to hit us over the head with this, essentially. So that was something that we thought would be good, that wasn't, and that happens sometimes. We did eventually adopt color, because when diastolic is high, it strays into the systolic goal band, and it's hard to tell the difference. And so we did abandon grayscale and went to using distinct colors. Our first choice was this blue and orange, but it actually ended up conflicting with our EHR vendors' color scheme for normal blue and out of control values in like lab data. And so the orange was their out of control color. And so they said, you have to change your color scheme because this is conflicting with our color scheme. And so we ended up with the final colors of the mint and cocoa that you see on the right. And I just included that because that's a funny little thing about the environment where you implement affecting your design. And this is our final design, where, again, we're aiming for intuitive design. So during our patient focus groups, we did not tell patients how to use these graphs. We did not orient them at all. We just put them up on a screen during a focus group and said, tell us about this graph. And even without this annotation that says ran out of lisinopril, couldn't get to the pharmacy, patients, even when we did not include that, patients were able to come up and say, as were physicians, you know, this patient stopped their lisinopril here in late July, and then you can see that their blood pressure goes up. And when they restart it here in mid-August, their blood pressure comes back down. And what was really funny is the patients in our focus groups actually got angry at this scenario. They said, why would they not be able to get to the pharmacy for almost a month? But the great thing about it was that it told us that the patients can construct a story with just what they see. And so we felt like we did satisfy intuitive design. And the patient says, I mean, it's doing great. And then this person quits taking the medication. It's just out of control. So they definitely got the story without us telling anything about it. This final design, you'll notice that in the background here is a lighter, jagged line of raw systolic blood pressure data. And then over top, we have this darker smoothing line. And so I want to tell you about the smoothing line, which is generated by a LOS algorithm that is sort of, I explain to patients, it's like a running average of the data. It's not exactly true, but it's a good way to talk about it. So variability affects the perception of blood pressure control. And to do that, I'm using these three graphs. And what you can see is that all of these graphs have the same mean. But when the variability increases, and in this case represented by standard deviation, it gets harder and harder to tell if the blood pressure is in control. And that's with a mean that's 10 full points below 140. As it gets closer, it's even harder to tell. And so we're trying to simplify that decision for patients. You can see that this is from our study of patients, and this question is the patient needs to change their medication. So this is for these graphs that you just saw, the mean of 130 is this blue line. And so this should be close to zero because the patient is in control. And you can see even with a little variability, it's still at 30%, but almost 70% likelihood they say that the patient should change their medicine when we increase that standard deviation, even though the mean is 130. What's really interesting is when it's clearly out of control, variability has less effect. But we don't want people like adding medication when a patient's blood pressure is in control and giving them hypotension. And so the smoothing line is potentially really important when there's high variability. And you can see how this data over here looks, the judgment of control is much easier when you have this LOS smoothing algorithm applied. And easy is what we really want for them because the mean is more important than variability. So how much does smoothing the data affect patients' judgments of control? This is from our study of that. And what you would want is that when blood pressure is controlled, you want the highest level. And so you can see that the smooth graph leads people to the judgment of control with either low variability or high variability more effectively with the smooth graph. But when it is uncontrolled, there's a little bump on low variability, but on uncontrolled, it's basically stays the same. And so we're not greatly affecting the judgment that blood pressure is controlled when it is not. But we are when it is, which is what we wanted. And then this is examining, well, you know, some people know how to interpret graphs, and for some people that's a little bit harder. And what's the effect of literacy and numeracy and graph literacy, in this case, graph literacy on judgments of control? I'm going to start, and we tested raw graph versus data table versus smooth graph. And I'm going to start over here with uncontrolled because you can see that no matter the form of data presentation or graph literacy, these all stay pretty tightly together, that the smooth graph doesn't increase the judgment of control much over either the raw graph or the data table, even when graph literacy is low compared to high. But for those who do have graph literacy, here on the right side of controlled hypertension, we're improving the judgment that blood pressure is in fact controlled, which we want to be more close to 100. And it improves even for those with lower graph literacy, but more so once you get to medium and up. And so that definitely has an effect. And so we have to think about how patients interpret designs. We wanted patients to be able to understand the story and for just an instantaneous, this is what's going on, and to have that be correct. A physician said, Vito, it's really just creating a story where you see what the blood pressure was when the medication started, where it changed. And the patient says, it shows clearly that when you add the hydrochlorothiazide and then you added the lisinopril, it looks like the combination of those made the blood pressure come down. And this is the storytelling and understanding what's happening with the blood pressure. And it's our objective that the patients really understand that. And so we really liked it when people were able to do this. The other thing that this does is we're really elevating the value of patient-generated health data here. When my patient brings in those 180 per month blood pressures to me on a single sheet of paper, it's hard for me to spend a lot of time looking at that and still accomplish the other goals of the visit. But when we incorporate their data into our electronic health record and reflect that back to them, we elevate the importance of the data and honor their effort in collecting the data. And we also signal that patients are an active partner and co-decision maker in managing their condition. We also enable them the same kinds of insights that we're making, which is what I'm alluding to here in the beginning. One of the patients told his doctor during a visit that monitoring the blood pressure and entering it made him quit smoking because he could see how when he smoked right before he took his blood pressure, it made the blood pressure go up and was really thwarting his doctor's efforts to get the blood pressure to come down. So a little bit about limitations and next steps. Our clinicians that we focused on were exclusively primary care physicians. But we did do a follow-up focus group with advanced practice nurses and care managers, which yielded similar results. We did implement in the EHR, but not the patient portal, but we're fixing that now. And we did not accomplish automated upload of data, but also working on that now. We have yet to really determine the flow of the home blood pressure data and who manages it. It goes into the EHR, but more active management would be helpful. And we need to figure out the logistics of a sustainable practice for using home data in between visits to improve control. So our next project is Coach with David Dorff from Oregon and I are leading this, and also with Vanderbilt. And we've incorporated this design into a patient-facing goal setting understanding of their cardiovascular risk and blood pressure and other lifestyle goals. I wanted to end with this screenshot that I took on April 16th, 2020. At this time, there were no patients coming into our clinic, and we had already implemented this. And this is my own patient who you can see that all of these are circles. They're all home blood pressures because no one's coming into the clinic in March, April 2020. And I was able to display this to my patient during a telehealth visit for hypertension and say, hey, looks like you're perfectly in control. Thanks for entering all this data during the screen share during my telehealth visit with that patient. And I think as a researcher, it's really rare to be able to do something that affects your actual clinic practice, your and the care of patients so immediately as this did, and furthermore to pre-design a solution for a problem that we didn't know we were going to have. So this was just an incredibly gratifying moment for me in the midst of what proved to be a very dark time. This is my contact information. I'd be glad to chat with people more about this, and we'll have time for questions at the end. I'm going to turn it over to Gabby, if I can.
Thank you, Dr. Koopman. As you mentioned, we'll be taking questions for all the presentations at the end, so please submit any questions you have using the Q&A panel. Were you able to move the...
I am trying. Yeah, sorry. There we go.
Thank you. Our second webinar presentation will be led by Dr. Gabriela Schmajuk. I'm sorry. Dr. Schmajuk is the Chief of Rheumatology at San Francisco VA Healthcare System and Associate Professor in the Division of Rheumatology, Department of Medicine at UCSF. Excuse me. Her research focuses on quality of care and patient safety in patients with rheumatic diseases. She co-directs the UCSF Rheumatology Quality and Informatics Lab, which is an interdisciplinary group that uses health services research, informatics, and implementation science to inform national healthcare improvement initiatives. Now let me turn over control to Dr. Schmajuk. Thank you.
Thank you for that kind introduction, and I think that our participants will see that many of the same themes from Dr. Koopman's talk will come up again for us here. So I'm a rheumatologist, and so my project that I'll be describing today is about building an electronic health record application to display patient-reported outcomes for patients with rheumatoid arthritis. So here's an outline of what we'll be going over today. Talk a little bit about what rheumatoid arthritis is and how we like to track disease activity and our strategy for treating disease. Then I'll describe our human-centered design approach to developing this data visualization tool and workflow. I'll talk a little bit about the implementation of the dashboard itself, and then describe the stepped wedge cluster randomized trial that we have undertaken and is ongoing. So very briefly, what is rheumatoid arthritis? As you know, this is a chronic inflammatory disease, affects women more than men. Symptoms include joint pain, stiffness, and swelling, in particular in the hands and the wrists. And then with long-standing disease, we see deformities and loss of function. We treat rheumatoid arthritis with immunosuppressants. Our first-line agents are methotrexate, and then we use newer agents that are biologics or targeted small molecules. So the problem with rheumatoid arthritis, as opposed to blood pressure, is that we do not have objective outcome measures. And so we rely on patient-reported outcomes to track disease activity over time. There are a variety of tools, validated tools, where the disease activity measure will correlate with long-term outcomes and damage. One of the easiest tools to use, which we have implemented in our clinic for the past 10 years or so, is the Clinical Disease Activity Index. And so this is a composite outcome where the physician counts the number of tender joints and the number of swollen joints. There's a patient global assessment. So you ask the patient how they're doing on a scale of 0 to 10 on a visual analog scale, and then a physician global. And there's a simple sum of those 4 components to give you a score. We also use functional status measures. In our clinics at UCSF, we've selected the patient-reported outcomes measurement information system, the PROMIS physical function, to follow over time. But other measures include things like HAQ and MD-HAQ. And then we also follow the pain score. And so we use, in particular, the disease activity score to treat to target, the same way that you might treat to target for hypertension or diabetes. We try to treat to target based on the CDAI score. And so we measure the disease activity using this CDAI at least every 3 months, and then we adjust the medications with the goal of having patients be in low disease activity or remission, which corresponds to a score of less than 10. And so our initial concepts for a visualization tool that we could use for rheumatoid arthritis was that we would communicate with the patient around what their CDAI score was, and then, have a shared decision about how we were going to improve their control. So the idea for the workflow was that data would be loaded into the dashboard that we were creating from the EHR. There would be a conversation about this dashboard during the visit. The data would be reviewed together, and then a decision would be made about changing medications. And so this was quite a journey for us. We started with, development of the visualization tool of the dashboard using principles of human design, and I'll tell you a little bit about the focus groups that we did. Then we worked with our technical team to build the application as a sidecar application to the EHR, because the visualization had to occur outside of our Epic EHR. And then I'll talk a little bit about the testing and the trial that is ongoing. So we had a kind of long series of interviews, semi-structured interviews that we performed, as well as focus groups. We had 45 patients from both university hospital and our county hospitals, which included patients with both adequate and limited health literacy. And actually, we performed the interviews and focus groups in both English and Spanish. We also worked with clinicians and performed 3 focus groups with 11 clinicians from our university and county hospitals, including attendings and trainees. And so we used, this time to work on understanding what information was expected to be seen during the visit and what the patients really wanted to get out of the visit in terms of medical, clinical decisions and shared decision making. So we have, I'm showing you here an early version of the visualization, which we had, put together with the very earliest interviews from the patients, and then after many iterations, the final version on the right. And I'll walk you through some of the features and some of the feedback that we received from our focus groups. So first, it was really important to patients that there be a goal. And so we had this green zone with a goal for disease activity that was low disease activity or remission. And then for physical function, a goal of the median or better on physical function. The goal for pain was felt very strongly that it should be 0. And so we don't have a green zone on the pain scale because we want to minimize pain. And that was really came from the patients. So there was a strong feeling on behalf of patients that up should be better. And so this is a challenge actually for the clinicians, because the CDAI score is a disease activity score, and so a higher number represents more disease activity. But we flipped the scale on this to accommodate the patient's requests that align toward the top of the graph represent a better state, a better status. This is a feature that we weren't able to build in the end, but patients really wanted to be able to track which joints were involved over time. And so this is kind of a simple homunculus that shows which areas of the body are most affected. It became kind of just a technical, time and feasibility issue to build this, but I think it is, a possibility for the future. We had a scrolling function, so we display 5 visits worth of data. The most recent 5 visits pop up immediately, but you're able to scroll backwards over time if you want to see earlier data from earlier visits. We tried to, avoid jargon. And so the CDAI score is labeled as my RA symptoms, the functional status labeled as how well can I function, and then my pain for pain. So there was a conflict between the patients and the clinicians on whether labs should be included in this dashboard. The patients are very, very focused on potential side effects from their medication, and they want to make sure that, you know, they're safe in terms of continuing their medication. So it was really important to them to include the labs. The clinicians kind of felt that, you know, if their labs were an issue, they would mention it, but they didn't want that to be a focus of the visit. And so this is kind of the compromise that we came to, that you can, you know, just see this message that says, you know, your labs look okay without the data itself. But if you want to click on the View Lab tab, it will pop open the laboratory data if for people who want to talk more about that with their doctor. And so then the workflow after discussion with the patients really changed a little bit. So, you know, we still load the data in from the electronic health record during the visit. The real-time data, the data from that visit, is input into the dashboard. There's the discussion. And then another request from the patients was that they be able to take the data home with them to either share with their family or with their other doctors. And so we did work to build in this feature of being able to print the dashboard so they could share it. We're also able to take a screenshot and paste it into like a MyChart message that then can be emailed through the portal. Okay, so now that we kind of did all of this groundwork to decide what the application should look like, we went on to the build. So in terms of the requirements, we wanted historical and real-time data from the EHR that included all the PROs. We wanted to be able to track scores over time. We wanted to be somewhat customizable, so we could toggle what was visible on the screen for the patients. We wanted the dashboard to be printable for after visit review. We wanted the dashboard to automatically launch within Epic, so it would be no additional work or logins on the side of the clinicians when they opened up the patient page. And then we also wanted to have user logs and analytics so that we could tell you know, how active the clinicians were in using the dashboard. So this, you know, there was a long process and regulatory review where we worked with our Institutional Digital Diagnostics and Therapeutics Committee that oversees the extraction of both historical and real-time data from Epic via the use of APIs. We decided to work with an internal technical team, which made this a little bit easier because they had relationships with these regulatory committees. So we had to decide on the architecture for this application, and ultimately we decided to build the dashboard using Salesforce as a sidecar application. Because there was like a baseline infrastructure there, we could really focus on optimizing the user interface as opposed to building something from scratch. There was, you know, a lot of customization possible in the user interface, and although it required data flow from multiple sources, we were able to pull both historical data preloaded, so it wouldn't slow the application down, as well as real-time data. The downsides was that the architecture is a little bit more complicated, and there's obviously a cost to license this sidecar application. And then this slide just shows us the dashboard auto launch, that when you open the patient chart, there's no additional work. You know, the homunculus, these are kind of native applications in Epic, and then our dashboard actually shows up as an additional panel on the same screen. So nudging our clinicians to use it. So I'll just talk briefly about our plan to test the application. So we've designed a staffed wedge cluster randomized trial, and we will test the hypothesis of whether having access to the dashboard will increase patient engagement, foster shared decision making, and maybe even improve health outcomes for patients with rheumatoid arthritis. We are able to provision access to our clinicians one by one, and so we've divided them into 4 clusters. They receive training and kind of at the elbow support in the first 2 weeks of having access to the dashboard. And then we just monitor its use over time. We have a lot of patient surveys that we do in order to assess our outcomes. We have a shared decision-making scale. We ask about medication adherence. We do a self-efficacy symptom management scale. And then we follow their PROs, disease activity, and functional status over time. And of course, we're also monitoring the clinician satisfaction and have time during the visit as a balancing measure to make sure that we're not prolonging the visit through the use of the dashboard. So I'll just share some first patient impressions with you from our early surveys. So the patients report that the dashboard gave me a better understanding of the history of my disease. One of them said, I'm interested in my disease progression and the discussion that follows with my doctor. I appreciate knowing how I'm doing compared to my last visit. And then the type A patients say, I like seeing that I'm in the green zone. And so you actually learn a lot about people's personalities as they react to seeing the dashboard. We have pretty good clinician engagement. So you can see these are the providers that are using it so far. Some of them, are full-time clinicians, and others are, researchers or fellows who might only have clinic once a week. But looking at kind of the proportion of rheumatoid arthritis visits in which the dashboard is used, we're between 20 and 50% for most people. And so I think that was pretty good for us. So challenges. We started building this application in the 1 or 2 months right before COVID started. And so our technical team had to take a long pause as they built, COVID screeners and all the interruptions that we had with the, huge rise in telehealth that happened in 2020. So that was one huge, long technical interruption in building this dashboard. We've also just over time run into EHR software upgrades, which then break the connection between, the Salesforce and our data sources. And so those need to be corrected if not anticipated. Obviously COVID brought on an explosion in the use of telehealth, which was really new to our clinic. I think we were at like 1 or 2% telehealth, and then during the pandemic got up as high as, 90% telehealth in March and April of 2020. But even today, we're still at about 30 to 40% of our visits are televisits. It's a huge problem for us because without a physical exam, we're unable to collect this disease activity score. And so we've shifted to focusing a little bit more on the physical function, the PROMIS score, which is completely patient reported. The telehealth visits also changed our workflows, made it harder to identify RA patients with the same flags that we had before. And so we had to work on changing the inclusion criteria for patients and who would have the dashboard pop up for them. We discovered new sources of data. There was a new PROMIS questionnaire implemented by an outside team that patients started completing that, wasn't feeding into our physical function data set. And so, constant feedback from the clinicians on, the patient said they filled out the questionnaire. We don't see it on the dashboard. What can we do to fix that? And then we also had some issues in capturing medications when they were infusions that were hospital-administered medications and not outpatient medications that were included in medication reconciliation. Issues with pragmatic trial logistics. You can't force people to use the dashboard, and we don't force people to use the dashboard, but people vote with their feet. And so if a clinician thinks that the patient is in a hurry or won't appreciate the dashboard, they don't use it. Clinicians perceive limited time to share and discuss the dashboard with patients. And so that's been an issue in using the dashboard. And then we have kind of a ceiling effect with our outcomes. The patients are generally satisfied with their visits, so it's hard to improve satisfaction. They report outstanding adherence to their medication, so it's hard to improve their adherence. And so we had to shift our outcomes a little bit. So what have we learned? Some lessons learned for others. So I feel that, putting patients at the center of this dashboard development really, helped us to develop something that was highly usable, that people, seem to appreciate. And having the patients be involved in that process really brings a lot of credibility to the design choices that we made, and kind of sharing with the clinicians, how their opinion might differ from those of the patients. It was really important to address the key features that we needed, but also the clinical workflows. For example, having a printout or something they could take home became a version of the dashboard they could take home became really important, and a key feature for us to build. Working with an internal technical team was kind of surprisingly beneficial. We had an option to work with outside teams versus inside teams. We ended up choosing the inside team, but I think it really provided us with a lot of benefits and unanticipated benefits in terms of the connection to regulatory committees and awareness of upcoming upgrades to the EHR. In terms of clinic rollout, I think we learned that we really need many clinical champions to encourage other clinicians to use and access the dashboard. And we've had kind of a series of check-ins and focus groups with the clinicians where we do kind of peer-to-peer demonstrations and teaching on how they've incorporated the dashboard into their own clinical workflow. And then in terms of maintenance, I think that we've learned that it's really it's a continuous improvement project. It requires infrastructure, time, funding, and energy, and many iterations to maintain a tool like this one. We have automated checks on quality, frequently check in about workflow and whether the data is flowing where it needs to be, continuous feedback from frequent users, and daily and weekly connection with our technical team and clinical teams to make sure everything is on track. So I'm happy to take any questions. It's just a picture of our lab, including our research coordinators and our trainees. Thank you so much.
Thank you, Dr. Schmajuk. Please feel free to submit any questions you have using the question and answer panel at this time. Moving on to our final presentation for this webinar, which is being led by Dr. Daniel Malone. Dr. Malone is a professor of pharmacotherapy at the University of Utah's Skaggs College of Pharmacy. His research over the past 21 years has focused on reducing the incidence of drug-drug interactions and improving clinical decision support for drug safety concerns. He also has experience in randomized control trials, economic modeling, and outcomes research using observational data. Dr. Malone has over 210 peer-reviewed research publications and over 240 total publications. And now I'd like to turn over control to Dr. Malone.
Thank you, Roland. And I'm not quite sure I have control yet. Yes, I do. Thank you very much. So I'd like to share with you the development of a tool that we developed for drug-drug interaction shared decision-making. We're a little bit less advanced than the other two presentations, so I'm going to spend a little bit more time on kind of our product development or our program development for this particular tool. So drug interactions are a preventable adverse event, and they happen, unfortunately, frequently. We know that they're responsible for about 5 to 14% of all medication adverse reactions, and the major reason patients are hospitalized. And they occur, obviously, at a high prevalence in older populations due to polypharmacy. Our particular tool we're going to talk about today is a warfarin non-steroidal anti-inflammatory shared decision-making tool. The reason that we selected this is warfarin is a narrow therapeutic index drug, but also has adverse consequences associated with bleeding. So we know that when patients are exposed to both warfarin and nonsteroidal anti-inflammatories, the increased risk of bleeding goes up an additional twofold. In addition, some epidemiological research that we and others have done have found that there's a lot of patients that are receiving a prescription for warfarin and have also received a prescription for a nonsteroidal anti-inflammatory agent, in addition to nonsteroidals being available over the counter. And finally, there are patient characteristics that will affect the risk of a patient's propensity to have a gastrointestinal bleeding event or other types of bleeding events. So we wanted to try to take that into account in the development of our tool. So this is a classic representation of the factors that are designed to prevent drug-drug interactions, and then the holes, which we call latent failures. So obviously knowledge of the prescriber, our computer systems, pharmacists, patient individual risk factors, things such as pharmacogenetics, drug administration, et cetera, all can lead to an adverse drug event happening in this situation. Our goal was to limit the latent failures and actually give some information back to both clinicians and patients to act on. Currently, most drug-drug interaction clinical decision support for clinicians is an alert, which generally speaking tend to be overridden or ignored. These alerts are drug specific. There's no patient characteristics that were brought into many of these alerts. There's really no quantification of the risk, just saying that it's a major drug-drug interaction or a contraindicated drug-drug interaction, but it doesn't really quantify what that term major or contraindicated really represents. Also, clinicians typically see this information, but patients do not. As a result, and just the ubiquitous nature of drug safety warnings, many clinicians tend to override these warnings. On the consumer side, consumers are really interested in knowing about drug-drug interactions. It's one of the most important things that they ask about when they go to the pharmacy or when they talk with their providers. Unfortunately, when you look at drug interaction resources for consumers, they're fairly limited, usually with text representation of the data, often at a high reading level, and doesn't necessarily take into account the patient's individual risk factors. So we developed a shared decision-making tool with respect to drug-drug interactions. Now, not all drug-drug interactions are amenable to a shared decision-making process. So with this process, we tried to follow the 5 steps for incorporating shared decision-making into development of tools and programs available to clinicians. So we sought our patients' participation. We helped them. We want to help them to explore and compare treatment options. We want to look at their preferences and values, reach a decision for the patient, and then evaluate that decision. So with that in mind, we started down the path of developing the tool. I'm going to show you the tool, then I'll tell you a little bit about our development of the tool. So this is a general overview, and I'll dive into the different sections of our particular dashboard. In general, we put the patient risk factors at the top, and then other factors are allowed to expand via an accordion function, depending upon what was selected. So I'm going to drive down to the bottom of the tool first, just because we've presented some consumer information available to the patient, so that it can be expanded to explain kind of the general notion of a drug interaction and what we're talking about with regards to gastrointestinal bleeding. We've also included an option for the clinician to create a after visit summary that could be cut and paste into chart notes. So let's go back up to the top of the tool and kind of just show you the different attributes that we've designed into this particular CDS. So at the top left-hand side, we have incorporated the patient risk factors So obviously, things such as aspirin, clopidogrel, or other medications that will increase the risk of a gastrointestinal bleed. We also know that patients who are older or have had a previous gastrointestinal bleed will also be at greater risk for having subsequent bleeding events. And then there are other medications that can be incorporated into, or that are incorporated into our tool, specifically SSRIs. We know that up to 15 to 20% of patients who are taking a oral anticoagulant are also on an SSRI. And then corticosteroids, glucocorticosteroids tend to increase the risk of bleeding as well. Below the risk factors is a risk array that's designed to represent the risk given the patient characteristics. We looked at various different designs of this particular representation of the risk and tried to follow best practices with developing this particular risk array. And we also explored side-by-side representation, but due to screen availability, we decided to keep it as a risk array, just a single risk array, but it's dynamic. So as things are toggled on or off, or medications are selected or unselected, the risk array will change dynamically. To the right of the risk array and the patient profile, we have shared decision-making points and also information about the medications. So I'm just kind of expanding those dialog boxes. So if the patient and the clinician decide to go to the oral steroid, the oral non-steroidal anti-inflammatory tab, we've represented different common treatment options, and by selecting each of these, the risk array on the left-hand side of the page will change dynamically. We also incorporated things that would allow the risk to be reduced by taking a proton pump inhibitor. And this is specific to gastrointestinal bleeding, won't necessarily affect some other types of bleeding. And we also included other common non-medication or other medications that may not affect the risk of gastrointestinal bleeding. These include acetaminophen, topical agents, as well as opioid medications. And you'll notice that we also, based on feedback from patients, we incorporated some dollar signs to represent the likely expense associated with each product. Unfortunately, we were not able to incorporate individual patient copays just because the data structure is just not there in the existing systems, in the existing AHR systems. So this is a schematic showing the Smarter Than Fire architecture associated with our tool we're calling DD Interact. Obviously, it incorporates basic standards associated with Smarter Than Fire, HL7, including using a CDS hook service, EBM on Fire, and a EHR Fire server. It's intended to launch within the EHR, although at current we haven't incorporated into our own EHR at the University of Utah. We have put it up on the Logica sandbox so that individuals can explore this particular tool. So now I'd like to talk a little bit about our development of the tool. The first part was just our design and usability testing that we had with respect to this tool. So we started with a relatively low fidelity prototype, and then we linked in features from the International Patient Decision Aid Standards collaboration and continued to do iterative testing with both clinicians and patients. So once we reached a stable prototype, we had 2 individuals who were trained in usability heuristics, use Jacob Nelson's 10-point usability heuristics for user interface design, evaluate the tool to make sure that there were no identified design flaws that could be addressed prior to our resource-intensive testing down the road. Once this was done, we started with patient interviews and a simulated clinic visit, and then we looked at clinician task performance using the particular tool. So I'll provide a little information about the usability with our healthcare providers first, and then we'll talk about the patients. So We were able to get a total of 11 individuals, seven physicians, and 4 pharmacists to evaluate the tool. This gives you a sense of their characteristics and experience with warfarin. We developed a series of scenarios and asked them to go through those scenarios and attempt to do certain activities within the app. And we timed their screen time from when they started the activity to when they actually completed. And these included navigation, patient education, finding pictures of multiple nonsteroidals was an early version of the tool. We had Prozac as a risk factor in one of the scenarios that we developed, et cetera. So generally speaking, we found that the mean time to accomplish these tasks was relatively short. We also asked clinicians to give us their opinion about the effort associated with using this particular tool. So this is a 5-item Likert scale that was from strongly disagree to strongly agree. All the items were rated at agree or strongly agree. So mean values from 4.27 to our top value is 4.36 on average across all of these items, 4.32. We asked 4 individuals who were chronic users of warfarin. These individuals had been taking warfarin for over 5 years to evaluate the tool. And here's some of the summary statements for them. I won't read them to you, but generally speaking, I think that we're giving patients something that was highly desirable. From that, we proceeded to do a formative evaluation of the tool. This was a randomized tool where we created dyads and we randomized them to vignette clinical encounters. So these were not actual clinical encounters, but we created a scenario for them to either use the tool or usual care. And usual care was instructions about the scenario as well as resources that they could access associated with drug-drug interactions, such as common drug interaction website programs. So the physicians and patients were instructed to behave as they would routinely behave. The patients that we included in the study were all on anticoagulations, although not everyone was taking warfarin at the time of the study. They had received either warfarin or a direct-acting oral anticoagulant. So our primary outcome for this was the shared decision-making 9 scale, where we assessed that from the physician's point of view. We also looked at system usability scale, which was adapted for both clinicians and patients. NASA task load index, where physicians completed this scale. The Unified Theory of Acceptance and Use of Technology, the UT-AUT scale that physicians completed, perceived behavioral control, and then the decisional conflict scale. So I'm going to quickly just show you those results. So across the shared decision-making 9 scale, there was no difference between the 2 groups with respect to reaching agreement or selecting a treatment or evaluating the options. However, so those are the top 3 items shown here. But all of the other items, facilitated discussion, assisting in patient comprehension, presenting advantages, disadvantages, presenting different options, involving the patient, clarifying the shared decision-making, all of those were rated higher among the DD Interact as compared to usual care. With respect to system usability scale, it was not surprising that we didn't see differences between the patients randomized to either the DD Interact or usual care. And there was some differences across some of these items with respect to physicians' ratings, such as the tool being logical, efficient, and helpful. And SDM using the tool was valuable. So with respect to our secondary outcomes with respect to the NASA task load index scale, only one of these items was significantly different between the 2 groups, and DD Interact being much easier as compared to using traditional web-based tools associated with drug interactions. With respect to the Unified Theory of Acceptance and Use of Technology, the UT-AUT scale, There are several dimensions where clinicians who were randomized to the DD Interact reported higher scores in terms of performance expectancy, effort expectancy, attitude towards using the technology, and social influence. Also, clinicians who used DD Interact had lower anxiety scores as compared to those that were using the traditional tool. And keeping in mind that most of the clinicians that were involved in this study were seasoned clinicians with many years of experience. With respect to behavioral control, again, from the physician's point of view, a couple items were significantly different. The first item, differences convinced about shared decision-making in the clinic could be enhanced with DD Interact compared to usual care, and also perform shared decision-making without extending the duration of the consultation. In fact, some of the verbal comments we received back from the physicians is kind of a post scenario debrief, was that they thought it would actually save them time as compared to trying to explain these concepts to patients. With respect to decisional conflict, now this is the patient's point of view, there was really no differences between the DD Interact and usual care with respect to these attributes about making decisions to avoid drug interactions. So in conclusion, with our tool, we think it's a novel tool designed to facilitate shared decision-making with a specific type of drug interaction. We think the tool will improve shared decision-making between clinicians and patients. However, further research is needed to evaluate the impact of DD Interact on reducing actual drug-drug interactions. It's kind of where we're headed next. As similar to what was presented earlier, trying to test this in an actual environment we're not there yet, but we're proposing additional research to be done in those spaces. One of the challenges that we came up with designing this particular tool is it was specific to warfarin and nonsteroidal anti-inflammatories. And we know that there's many patients that are now taking direct acting or novel, depending upon how you want to define it, oral anticoagulants, such as rivaroxaban, apixaban. So we're redesigning the tool to incorporate those other medications that may be associated with increased risk of bleeding. So with that, I'd like to thank my collaborators. Our technical group spent a lot of time developing the tool, and that was primarily Dr. Rees and Dr. Jeremy DeFoyle at the University of Utah, one of my collaborators here at Utah, and then a wide variety of other clinicians and researchers across a number of different organizations, including the University of Pittsburgh and the University of Arizona. So with that, here's my contact information. If you have questions about the tool or like to reach out to me, and I'll turn it back over to you, Roland. And I'm going to navigate to the panel to give you the screen share.
Great. Thank you, Dr. Malone. And thank you again to all our presenters for this very informative presentation. We tried to show some of the data visualization from what goes into the conceptual design of it to kind of how do we use these visualizations at the end for shared decision making during the clinical encounter. So that was kind of the trend of all three of the presentations going forward. As a reminder, please submit any questions you have for any of our presenters using the Q&A panel. And I think we'll start with this concludes the content portion of the webinar. We're going to do a few questions right now. And we may not be able to get to all the questions today, but we will provide responses to all the questions we don't get to in writing. And you'll receive an email once the responses are available. Dr. Koopman, I'm going to start with you. There were a number of questions in the chat as well that kind of relate to this question. But looking at the passive continuous sensors that are becoming more common, if a reliable blood pressure monitoring becomes commonplace, such as a wrist-worn device watch, how can data visualization handle this amount of data?
So that is really difficult. The EHRs usually have bounds on how much data they can present during a certain amount of time. And our group actually developed a binning algorithm, that's B-I-N-N-I-G, for combining data when it got to be too large to be accommodated. Now, we've never tested that with continuous data, but if someone's doing 6 blood pressures a day, we can combine that and represent an average in a point. So there's obviously pluses and minuses to that, but the plus is always clarity of presentation.
Great, thank you. Dr. Schmajuk, are there additional features that you're thinking of incorporating into your application in the future?
Yeah, so I mentioned one that we'd love to, get the data about what particular areas of the body are affected. That was, really highly requested by our patients. There have been a few questions in the Q&A about granting patients direct access to the dashboard, and we haven't really planned for that yet. They are able to take like a static version home with them, but they don't have access to the version, that the clinician has in the office where they can scroll backwards and toggle the different pieces.
Great. And Dr. Malone, you mentioned this briefly, but it seemed like this version of DD Interact was included warfarin, but there's other oral anticoagulants that could be considered. Are there plans to incorporate these and other medications in your work?
Yeah, so that is the plan, Roland. And one of the challenges that we have in the drug interaction space is the evidence for drug interactions is relatively thin. It's usually based on case reports. So as the other or the newer anticoagulants have accumulated experience, and reports are now being published about the risk of harm associated with these medications in combination with other medications, we're starting to be able to incorporate those attributes or those risk profiles into our calculator in the background. So the goal is eventually reach or get to a point where we've got all of that incorporated into a single calculator, so that clinicians and patients can explore the risks and trade-offs associated with taking medications, and then obviously trying to mitigate that harm via maybe using a medication designed to limit the risk of harm, such as proton pump inhibitor. So,
thank you. Yeah, Dr. Koopman, back to you. Your work focuses on representing blood pressure in the AHR for the clinician to share with the patient. So what can the patient see in their own portal?
Yeah, so our project did design for the EHR. The patients entered their blood pressure in the portal, and then the patient-generated health data ported starting in 2018 over to the electronic health record and was visualized within the electronic health record. And so the answer to that question is not what we designed. They could see a history of their blood pressure presented in a not very user-friendly way. But our current coach project, which I'm leading with David Dorr at Oregon Health Science, takes our visualization and combines it with goal setting and is included in the patient portal. So we're designing and implementing and eventually testing that right now.
Right, and I think Dr. Malone and Dr. Schmajuk, I think you had similar feelings, not quite as long or as detailed, but you were exploring the space also. So I wanted to see if you have any additional input to that question.
Roland, could you repeat the question? I was actually scrolling through the Q&A questions there, so sorry I didn't quite catch that.
Representing, the patients are the data is being represented in the EHR. What work is going forward for the patients to be able to have access to that data or to see that display themselves?
Yeah, that's a great question. One of the things that we've discussed, although again we're not as far along as my colleagues are, we've discussed the availability for the patient to log into their health records and pull up the tool without a clinician present, so they could investigate that. We're also exploring development of web-based tools that they could access outside of the HR environment. Because, quite frankly, we recognize that not all patients are going to go to our clinics to receive care. And we were trying to make this a more universally available tool as compared to, embedded within an electronic health records situation. That said, we did try to develop our tool based upon HL7 standards such that it was EHR agnostic. So it didn't require to be implemented in one specific type of EHR environment versus another.
Right. Dr. Schmajuk, do you have anything to add to that? I know you were thinking about it a little bit, but you may have already...
Yeah, we were thinking about it a little bit, and then we there was also a question, I think, in the Q&A about how that works with Salesforce. And to be honest, we were discouraged from pursuing this, by our technical team, because I think there's mostly because of like authentication issues and accessing it. And so we didn't prioritize that, but I think it is possible, but it might require, it might not be like single sign-on through the portal. And so then to have to maintain like, credentials for all of the patients who might want to log in and take that IT role was beyond, beyond the scope for us.
Yeah, and I think we at AHRQ, we've had some additional projects and seen this is a difficult project, a problem to solve going forward. So, and you brought up all the different parts of it that make it more complicated as well. So thank you. And then again, a follow-up question for you. You talked about, you're developing the application. So how will you maintain this application once the funding on your project ends? And again, this might be a question for all the panelists as well. The sustainability issue, I think, is really large. And is there institutional support available for you?
Yeah, I mean, it's literally the $1 million question. We do have a group, connected to our kind of regulatory committees at UCSF that is interested in, funding projects that have been shown to, improve the bottom line. I'm not sure we're going to get there with the trial that we have because, as I mentioned, some of the problems with our outcomes and problems with, collecting data from telehealth visits. But I think that would be the pathway, right? That if there's something that's already been built that requires kind of, a constitutive, maintenance cost, that maybe the institution would be willing to take that on if they thought that it improved the care of their patients.
So Roland,
go ahead.
I'll jump in on that issue just a little bit. Yeah, I've thought a lot about that because am I creating a one-off scenario here, and once my grant's over and once my interests have moved on to other things, to try to get other funding for other projects, which is probably not going to happen for a while because I really like this project. But the reality is, eventually, there is somebody that needs to take over maintenance if it's going to be embedded within the EHR and continue to be used. I think realistically, the goal, at least from my perspective, is to eventually have the vendors who create the EHRs and maintain those EHRs, take on these tools and use them or use something similar to these tools in their development so that it helps clinicians provide care. I think we rolled out the, many of the electronic health record systems without testing a lot of the functionality and hence we have huge override rates, at least in the medication safety arena, because it was promoted as a benefit, but not well designed from the onset. So hopefully over time, we're going to get to smarter information being delivered to clinicians such that these tools become embedded as a part of care to process and improves the efficiency of care and improves the safety of care simultaneously. But we need this groundwork research to be done first to kind of get there.
I think the answer lies in having the EHR vendor adopt and therefore take over the maintenance of the tool. And for them to do that, there has to be demonstrated value. And that can be by just action, like their analytics of use. If people are using the tool a lot, you develop something that people want and need, then people will not be too excited if you get rid of it or are not upkeeping it or it's not working correctly. And so also, I mean, ours is maintained in the University of Missouri instance of our electronic health record. We were hoping that the larger company would pick it up so that it would become part of what other institutions could use, but they passed on that. But that's okay, because we're continuing to iterate and we're creating this patient portal tool that patients will be able to use. And I think that hooking in with clinical governance and clinical objectives is really important. And so luckily, blood pressure is a very important metric. And it's also, as Gabby said, a really measurable one. And for example, our health system was going to contract with an outside entity to help patients with self-management of blood pressure. And luckily, they came to me and I said, don't do that. We're doing that right now, and you can have it for free. And it will probably be better because it will hook into the electronic health record. The platform that they were going to be using was an independent company, and you were going to have to log on to a separate website to be able to get the patient data, which is very 2010 and just not very effective. And so I think we're designing a much better solution for them. So hooking into the values of the institution, providing value to the EHR company, and I think evolving, right? So we're still working in this space, and that helps keep it alive.
Great, thank you. And then Dr. Malone, again, your app has the ability to do different scenarios and display that information. You can share it with the patient. But if they wanted to look at comparing different scenarios simultaneously, are you able to do that?
Yeah, Roland, that's a great question. We actually did a side-by-side tool initially early on in our development, but we were concerned about the real estate available on the screen. So given that was going to take up a little bit more real estate than we figured we were going to be able to get, we decided to do more of a dynamic option so that you click on or off risk factors or medication choices, and that would dynamically change the risk array. So and it's always a question, how much screen space are you going to be able to get? We were trying to anticipate the situation where a clinician might even have just something like an iPad or small tablet device in the patient room, and therefore wouldn't have a lot of real estate to do multi-scenarios, even though that might be of interest to the patient and the clinician. So there's always trade-offs here. So we kind of ruled that one out early on in our prototype development, though.
So I'm going to the question and answer now. I think this one, again, probably has input from all. And Dr. Koopman, so you already answered it, but we'll start with you anyway. How are patients entering the data exactly into your system?
Sure.
You talked about this huge amount of data as well, and I think you may have multiple ways of responding to this.
Right. Ours was through a tethered patient portal. I should say that if you're going to use Bluetooth, and it was manually entered by the patients after taking their blood pressures at home, which of course they can do in any way that they like, right? They don't necessarily use American Heart Association rules. And so that's a definite limitation that we have to realize in validating those blood pressures. And their method is as important if they're entering their data than if they're writing it down on paper and you're using it in the clinic. So they're entering it in the patient portal. As far as Bluetooth upload, the thing that we've really found to be important is that you need to get a dual channel cuff, because people measure other people's blood pressure on their blood pressure cuffs. And you only really want patient on channel 1 and other people on channel 2. And so a dual channel is really important.
Great, thank you. Dr. Schmajuk, you look like you had something to add to this as well.
And I mean, I understand the the issue with multiple people using the blood pressure machine. My kids check their own blood pressure on my machine all the time. I was just answering one of the questions about kind of gathering continuous user feedback from clinicians and patients. And the question was, how to encourage participation. And so I was just about to write, we have research coordinators who obviously, require resources, but they have offices in the clinic. And so they train our clinicians and provide this kind of at the elbow support that I talked about. And then I think that creates a relationship where there's, they can elicit feedback from the doctors and from the patients as well. So it's kind of built into our process that we'll get that feedback from people.
Thank you. Dr. Malone, I don't know if you have anything to add on this question.
Well, the great thing about medications, at least prescription medications, is they do, kind of feed into the data streams into electronic health records, via standards. So medication information has been collected a long time electronically. I guess the missing hole, or the hole missing in the AHR data with respect to medications, is things that are taken over the counter, perhaps episodically, that are not necessarily well captured by existing systems. So you really have to ask the patient for that. There was a question about medication reconciliation. That'd be a great time to bring that information into the EHR. And the EHR systems do allow medications to be added to the system such that you could then incorporate that into, our tool or other tools where you're trying to look at medication safety related issues. So, getting this information into the systems on the medication side is a little easier. Other attributes, though, if they don't occur within your healthcare system, it becomes really challenging. And, I think everybody is really hoping that eventually we're going to get to the point where we can dynamically transfer health information between providers versus such that it updates automatically, and we don't have to go to requests for it. Unfortunately, it seems like, that's shooting for the moon at the moment with regards to where we are in these systems, but hopefully we'll eventually get there so that no matter where the patient goes, the data follows them such that they're able to have that information available to the medical community to make better decisions for those patients. So.
Thank you, Dr. Malone. I think we've run out of time for questions and answers right now, but I think most of them were answered already in the Q&A box. So, but any that haven't been responded to, we'll get to later. I'd like to thank everybody for attending today's webinar. For those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on this slide. You'll select today's webinar, which will be indicated by the date and title to claim your credits. You have 14 days to claim your continuing education credit. Upon exiting today's webinar, AHRQ is asking to fielding a brief evaluation. We hope that you will have time to complete the survey and share the feedback with us. We use it in all our future webinars as well. Thank you again for everyone, and hope you have a great rest of the week. Thank you.